Building block 3, empanelment, calculating and weighting panels. Empanelment, the third building block in the 10 building blocks of high-performing primary care, is the process of linking each patient with a specific primary care clinician who serves as a regular source of care. Note that in a solo provider practice, all patients are considered automatically empaneled to that provider. Mastering the mechanics of empanelment, however, allows us to identify our active patients, our patient panel size, and our capacity and demand as a practice, all of which lends power to the other improvement efforts, whether in a solo provider practice or a multi-provider one. At a practice level, empanelment also aims to understand who is at home in the medical home. In other words, empanelment allows us to identify which patients are attached to a practice, whether primary care or specialty, and see that practice as the regular place for obtaining care. So why does empanelment matter? By defining which patients and how many our practice serves, empanelment enables us to get accurate data to drive our improvement efforts and facilitates patient care team continuity and healing relationships. When balanced with capacity and demand in mind, empanelment can help promote timely access to care by helping us to anticipate the number of visits our patients create and to align that number with the actual number of visits available in our practice. Empanelment is furthermore the foundation for population health. When we understand the discrete patient populations we serve, we can more systematically examine and address their care needs. We've briefly reviewed the importance of empanelment and why it matters. But what are the mechanics of empanelment? How do we begin? The first step in creating a robust empanelment framework is to determine who our active patients are. In other words, we look at active visits in a certain time frame to determine which patients are receiving regular care at our practice. Most practices choose a time frame ranging from 18 to 36 months, with 24 months being a common period. Generally speaking, a period of 12 months is too short because healthy individuals often do not seek care for more than yearly well checks, and a period of more than 36 months risks including patients who have changed practices. Typically, we begin by working backwards using electronic health record or claims data, which provide details on patterns of care to identify which patients have had established visits in a given time frame. Let's say, for example, that we decide to use our EHR data or claims data to list all the patients that have had at least one visit in the past 2 years. Once we have this list in hand, we need to decide which types of encounters qualify a patient as active. For instance, are we only counting patients who have had at least one preventative care visit? What about patients who are participating in virtual encounters more frequently than in-person encounters? Are telephone calls eligible if, for example, a patient has had a prescription refilled in the past couple of years without actually having a face-to-face visit? Does a patient portal message count as an encounter for that matter? Most electronic health records provide a way to designate active patients and run quality metrics based only on those patients. For practices using paper records, there are a variety of registries that can help to monitor panels and track preventive and chronic care needs of active patients. For patients identified as inactive, We may want to consider if and how we want to re engage them in their care. For example, some practices reach out to patients with letters or phone calls to ask if they wish to come for a preventative care visit or if they have established care elsewhere. Note that many practices have a shadow panel, a list of people who have been assigned to the practice by a payer, but who have not yet engaged with care. Some practices conduct outreach to this shadow panel to establish care before an urgent issue arises. Proactive outreach to shadow panels may help to improve preventive and chronic care quality measures, which can have direct financial impact on practices if a portion of their income is through value-based payments. Once we've established our criteria for defining an active patient and created a list of patients who fall under that category, we need a method to assign patients to specific clinicians or teams. For solo practices, assigning a primary care provider is easy. Other practices can apply an algorithm. One of the most common is Mark Murray's four-cut method. Patients who have seen only one provider for all visits are assigned to that provider. Patients who have seen more than one provider are assigned to the provider they have seen the most often. The remaining patients who have seen multiple providers the same number of times are assigned to the provider who performed their most recent physical or health check. The remaining patients who have seen multiple providers the same number of times but have not had a routine physical exam are assigned to the provider they saw last. Alternatively, we can allow our clinical teams to talk through this list of patients and determine where they belong. After creating a preliminary assignments list, it's important to check with clinicians to see if they agree. This step may lead to some juggling of panels. Empanelment is fundamentally about reinforcing care relationships, and clinicians may have insights about who is best equipped to care for a patient that are not reflected in the numbers. After clinicians have reviewed the lists, the results should be a working patient panel list for the practice and for individual providers. Patients are a key partner in understanding and supporting empanelment, so don't forget to include them in the discussion. Some ways to do this include notification letters, particularly if the assigned provider has changed, cards showing the primary care clinician and care team, and standard scripts for the front desk to confirm the primary care clinician upon each visit. Patients may have values, preferences, and communication styles that cause them to prefer some clinicians over others. Patient-centered care means respecting those preferences to the greatest extent possible. When a patient expresses a desire to change their primary care clinician, it is generally best practice to honor those preferences and provide alternatives. Front desk staff play a key role in helping facilitate reassignment and should be trained in how to respond to requests for reassignment. At this point, we know how many patients are active in our practice. We also know who they are and which providers they're seeing. With this information in mind, let's discuss how we can calculate our ideal panel size. Here's the basic formula for calculating panel size. Let's say we have a family doctor, Dr. Jane, who's in clinic 210 days a year. On an average day, she sees 18 patients for visits, which means she has 2,780 visits available per year. Now, to determine the average number of visits per patient per year, we divide the number of unique active patients at Dr. Jane's practice into the number of visits to the practice that these patients generated within the same period. At Dr. Jane's practice, 3,000 patients generated 9,000 patient visits during a 1-year period. This means that there's an average of 3 patient visits at Dr. Jane's clinic for that 12-month period. If we divide 3,780 by 3, we see that Dr. Jane currently has a panel of 1,260 patients. How do we now calculate Dr. Jane's ideal panel size? To compare it to the actual number of patients she currently has, we can calculate Dr. Jane's ideal panel size using the following equation. As previously mentioned, Dr. Jane has 3,780 visits available per year. We divide that figure by 3, which is the average number of patient visits a year at her practice. This gives us the figure for her existing panel size, 1,260. To calculate her ideal panel size, we multiply this figure by Dr. Jane's clinical full-time equivalent, also known as clinical FTE. Let's say Dr. Jane's FTE is 0.9. 1,260 multiplied by 0.9 gives us 1,134. Dr. Jane's ideal panel size is therefore 1,134. Her existing panel is 1,260, which means she's over-empaneled by 126 patients. This may explain why Dr. Jane's patients struggle to get an appointment with her. It's worth noting that there are no national standards for panel size for a full-time clinician. Panel size across organizations and primary care specialties can range from 1,250 to 3,000 patients per clinician. As we've seen, there are several factors that influence panel size, including number of patients seen per day, a clinician's clinical FTE, care team support models, and patient complexity. An internist seeing more patients with complex care needs may have a higher number of patient visits per year and therefore less panel capacity compared to a family physician or a pediatrician. This brings us to panel weighting. Panel weighting is the process of adjusting panel size for differences in patient complexity and primary care physician work effort. A panel of 2,000 people who are mostly young and healthy requires far less work than a panel of 2,000 people who are elderly and in poor health. However, many practices do not risk adjust their panels, and accurate panels are helpful even if they are not yet risk adjusted. There are many risk adjustment algorithms available, both as products within specific electronic health record platforms and other proprietary models that can be utilized. A practice attempting to risk adjust panels for the first time might consider adjusting simply based on age. In panelment expert Mark Murray's Family Practice Management article, Panel Size: How Many Patients Can One Doctor Manage?, include a guide to weighting panels by age and gender. More complex risk adjustment methods address comorbidities, social determinants of health, utilization patterns, and other predictive analytics. Resources for these more complex risk adjustment methods include the Charlson Comorbidity Index, the Minnesota Department of Health Care's Coordination Tier Assignment Tool, and the Johns Hopkins Adjusted Clinical Groups ACG system. As we've seen, empanelment allows us to determine our practice's workforce capacity and our patient demand. Defined panels also provide a denominator for performance measures at the clinician and team level. For example, if a clinician's panel includes 200 patients with diabetes and 50 of those patients have A1C greater than 9, then 25% of that clinician's diabetic patients are in poor control, and the clinician's team can find out which patients they are and intensify their care. Without empanelment, clinicians would not know their diabetic performance, nor which patients need additional services. Empanelment enables us to stratify our patient population in order to implement proactive population management. As primary care moves towards models of value-based payment, we are being paid increasingly based on our ability to produce health. Empanelment allows us to understand the needs of our patient population and target our efforts to those people who have not received necessary care or reached clinical goals, thus enabling us to provide tailored care to improve health. A robust framework, empanelment framework, is a cornerstone of a high-performing practice, and being able to identify our active patients, our panel size, and our capacity and demand as a practice are crucial for facilitating effective improvements.